Hey everybody, this is Eric back with you with FlightBridgeED. Thanks for joining me. I'm going to do a 3 podcast series on acid-base balance. I know that this is a pretty broad topic, so I know I'm going to break this up into 3 parts just because there's so much information. The first podcast, we're going to start with a patient scenario. We're going to go back and use the same patient scenario that I used for the PRVC, pressure control ventilation scenario, and so you may recognize that. We're going to go through and we're going to talk about pH, we're going to talk about PaCO2, bicarb, base deficit, and we're going to real briefly go through lab values real quickly. That's going to be more of podcast number 2. We're going to look at your normal pH. We're going to look at the range of pH, the range of PaCO2 and bicarb, and kind of break that down into a systematic approach so you can identify that really easily and quickly. And so that should wrap up podcast number 1 on this series. And again, we'll do podcast number 2, and we'll go over lab values. We'll go over strong acids, weak acids, how sodium and chloride affect our acid-base balance. We'll talk about albumin. We'll talk about potassium and kind of how all that plays into acid-base balance. And then podcast number 3 on this series, we're going to go and we'll start talking about the Winner's formula. We'll start talking about affecting pH by increasing or decreasing our CO2, how that affects pH. Same thing goes for bicarb and potassium and how all that kind of is intertwined. So hopefully after this 3-part series, you'll have a good understanding. I'm going to put all this literature in the podcast forums and attachments page under the forums, so you can refer to all that, and hopefully you'll get a lot out of this. We'll start out with a scenario. We got a dispatch to a transfer at a small rural hospital ICU for a 50-year-old male with sepsis and ARDS. He's currently intubated on the ventilator. I'm not going to go into the ventilator modes because that's not the basis of this podcast. But his current ABGs at this point, he's got a pH of 7.10. He's got a PaCO2 of 60. He's got a bicarb of 16, and he's got a PaO2 of 40 with a base deficit of negative 10. All right. His lab values, he's got a sodium of 128. He's got a chloride of 109. His albumin is 3.2, and his potassium is 7.1. And his BUN and creatinine are normal. Okay, we'll get again to those labs regarding the sodium, chloride, albumin, and potassium in podcast number 2, but I wanted to throw those out there just so you can kind of start thinking about that, maybe bring some curiosity in how those apply. So let's start off with pH. Everything in our body is driven off of pH. Obviously, we want a normal pH. A normal pH is 7.4. Will cause a homeostasis in our body. So that's what we want. Any deviation below or above the norm is going to either cause an acidosis or an alkalosis. All right. So a normal pH again is 7.4. The pH range that you would see in a textbook is going to be 7.35 to 7.45. When you talk about what is an acid and what is a base, we can look at pH and we can identify that if it's below 7.35, then we have too many acids, and that's going to be an acidosis of some sort, whether that's respiratory or metabolic. If it's greater than 7.45, that means we have too many base or not enough acid, and we have an alkalosis. Okay? So when we talk about breaking down acid-base balance, the quickest and easiest way is to name everything. So just like we have a first and a middle and a last name, we can use that same theory, and we can do the same thing for acid-base balance. So let's do that. Again, our normal pH is 7.35 to 7.45. So when we talk about that range, that means that's compensated. If we are below the 7.35 or greater than the 7.45, that means we're uncompensated. So we need to understand kind of the difference there. And again, then a normal pH is 7.40. I want people to understand that because I think it's very important to know that a normal pH is not 7.35 to 7.45. That is not normal. A normal pH is 7.4. All right, so if we look at a few pH values real quick we can identify. We're going to look at it and we're going to give the pH a first name. Okay? So is this we're going to say, is this compensated or uncompensated, or is this normal? So the first pH we're going to look at is 7.22, and that pH is going to be uncompensated, all right, because that's below 7.35. 7.10, again, correct, it's going to be uncompensated. 7.49, that's going to be uncompensated, but remember that's going to be an alkalosis, and that's greater than 7.45, so we know it's uncompensated, but it's on the alkalotic side. 7.40, all right, if you said that's normal, that's correct, it's normal. And 7.35, all right, that's going to be compensated. We're in that range of 7.35 to 7.45, so we're still compensated, all right? So that's our first name. All right, what's our last name? So what we want to first identify is this: what's our first name and what's our last name? All right, so we've identified all 5 of those pHs. We have a first name, whether it be compensated, uncompensated, or normal. And now we need to look for what the last name is. All right, so what the last name would either be an acidosis or an alkalosis. And like I said before, if we have too many acids, our pH is going to drop. So anything below 7.35 is going to be acidosis, right? And we don't know if that's metabolic or respiratory yet. We just know it's an acidosis. If it's greater than 7.45, we have too many base, or you could also say we have not enough acid, and we have an alkalosis. All right, so let's go back to those same values. We're going to name our first name and our last name. We're going to do it together. So 7.22 we know is uncompensated, and that's below 7.35, so that's an acidosis. So that's an uncompensated acidosis. 7.10 is going to also be an uncompensated acidosis. 7.49, that's going to be an alkalosis, right? And it's uncompensated because it's greater than 7.45, so we have an uncompensated alkalosis. 7.40, well, again, that's normal, so we can't identify it either way. That's a normal pH. That's good. And then 7.35, that's going to be a compensated value, and we would need to look at the respiratory side or the metabolic side to identify if this is an acid or a base. Okay, and so in that one, that's kind of a little tricky, and we would need to look at what value, whether it be the respiratory side, the PaCO2, or the bicarbonate side, the metabolic side, which is the kidneys. Is that affecting our pH? Okay, so a 7.35 is still compensated, right? We still have a normal pH. We may just have another value that's elevated or decreased to compensate for that. All right, so let's look at what else we're looking at on a blood gas. Well, we have our pH. We talked about that. We also have a PaCO2. Okay, PaCO2 is very important, right? And so whether we have a high PaCO2 or a low PaCO2, it's usually directly related to minute ventilation. All right, so if CO2 is an acid, all right, CO2 is an acid, we have too many acids, then an increased PaCO2 above the norm is going to be an acidosis, right? So what is our normal PaCO2 range? Well, it's 35 to 45. And if you remember back of our normal pH range, is 7.35 to 7.45. And if you just drop the 7s off of that value, that is your normal PaCO2 range as well. So if we have too many CO2, we have too many acids, that means we have an acidosis, and that's a respiratory aspect, okay? The next phase is we have bicarb, right? And bicarb is going to be a metabolic disorder. It's going to be related to the kidneys. And so if you think about this, your normal range for bicarb is 22 to 26. Bicarb is either going to give you more base or more acid, right? And it's going to be doing that by affecting hydrogen ions. If we remember, hydrogen ions are a strong acid. They're a positively charged compound, and the more hydrogen ions your body releases, it's going to convert, and your CO2 is going to increase. So let's quickly talk about the different buffering systems real quick, and then we can go back to that, because I probably should have started that with first. The first buffering system that we have is called the carbonic acid buffering system. And this is a buffering system that happens constantly, within seconds. But the problem with it is it's easily overwhelmed. And so the way it works is 70 to 75%, I believe, of CO2 in your body is converted into carbonic acid. That carbonic acid is then quickly turned into bicarbonate. Okay, so that's how the carbonic buffering system affects change, and it does it by the CO2, and it turns that CO2 into bicarbonate. All right, with the carbonic acid as the central intermediate thing that affects bicarbonate in conjunction with water, hydrogen ions, and carbon dioxide. All right, all three of those things affects the carbonic acid buffering system. The next thing we look at is the pulmonary compensation aspect, right? And that's the respiratory phase. And so your respiratory compensation happens within minutes. And this is going to be regarding minute ventilation. So are we increasing our breathing, or are we decreasing our breathing? Are we hyperventilating, or are we hypoventilating? We're going to get into causes of the respiratory acidosis, where you just have a respiratory component, and that'll become a little bit more evident of what causes it. But essentially, you're causing an increase or an inability to blow off CO2 is the problem. If you have an increase in CO2, you're going to drive the pH down, right? Because CO2 is an acid. More acid is going to cause the pH to become more acidotic, if you guys understand that, right? We need to understand that that's usually corrected pretty easily when we have that. So the carbonic acid buffering system is seconds. The pulmonary aspect, or the pulmonary compensation, is minutes. And then the last one is the renal compensation. And this kicks in, hours to days. And it kicks in when the other mechanisms, the carbonic system, the pulmonary system, become ineffective. And generally, like I said, 6 hours, days, and it will affect or be affected based on the acidosis or the alkalosis. So while the respiratory compensation occurs almost immediately, the renal mechanisms can take hours to days to make a difference. In acidosis, for instance, the kidneys excrete hydrogen, right? We know hydrogen is an acid. It's going to increase the amount of acid in the urine, and it's going to retain bicarbonate, right? If you have too many acids, and bicarbonate is a buffer system, right? Bicarbonate is a base, let's say. And if you look at hydrogen ions are positively charged. Bicarbonate ions are negatively charged. So it's constantly trying to counterbalance. You're excreting hydrogen ions, your kidneys are excreting those, and it's holding on to bicarbonate. In the other sense, an alkalosis, the kidneys excrete bicarbonate and retain hydrogen ions. Remember, and the whole process here either negatively affects pH in the acidotic range or the alkalotic range. So if we go back to our blood gas on this patient, we had a pH of 7.10, we have a PaCO2 of 60, and we have a bicarbonate of 16. All right, so if we start with our pH, we have a pH of 7.10. That's an uncompensated acidosis, right? We look at our PaCO2, we have an increased CO2, right? Because our normal range is 35 to 45, and we have an increased CO2 significantly by 15 points. That's more acid. We have more acid there. And then we look at our bicarb, and our bicarb normal range is 22 to 26. We're losing bicarb. So this is kind of a tough one. I'm not gonna get into this, but this is what's called a mixed disturbance. So you have two problems here. All right. So this patient is septic, right? This patient is septic. So he's either hypoventilating, and that's what's causing the respiratory aspect, but the underlying aspect is probably a metabolic acidosis. If you have a low bicarbonate level, that's going to cause more acid. Okay, if you have a high bicarbonate level, that's going to cause more base, right? Because bicarbonate is essentially a base. So if you have too much base, you're going to have a high bicarbonate level. This patient has a low amount of bicarbonate, and so he has a metabolic acidosis, and he probably has an underlying small respiratory acidosis as well, and it's probably related to his ventilator settings. And so we'll kind of get into that in a little bit and help you guys understand. All right, so let's talk about respiratory acidosis. All right, since we have an understanding of our pH range, we have an understanding of our PaCO2 range, we have an understanding of our bicarbonate range. So respiratory acidosis, think about this. You have an acute increase in PaCO2, and it's accompanied by only minimal changes in your normal bicarb levels, because bicarb, remember, is a late thing. It's hours to days. Over a period of, let's say, 1 to 2 days, though, the renal system jumps in, and it's going to start conserving bicarbonate to try to offset that pH. All right. So remember, the respiratory acidosis side is going to be initial. It's going to be minutes. And so, but when you start getting the kidneys involved, that's going to be a few days from now. So if you ever look at blood gas and you have bicarbonate levels that are affected, because the bicarbonate levels are metabolic in disorder and they're the kidneys, then you know that this derangement has been happening for a few days. When we talk about respiratory acidosis, so we're talking about minutes, maybe a couple hours, okay? Essentially what we have is we have retention of CO2. For some reason, either due to hypoventilation, we have a drug overdose, patients stop breathing, we have a VQ mismatch, we have a retention of CO2. And our body cannot remove the CO2 from our plasma and our lungs. All right? So when we talk about hypoventilation, when we talk about minute ventilation, remember in the ventilator podcast, I talk about minute ventilation and how important minute ventilation is to eucapnia, to a normal CO2 range. And you can already see, based on the values and kind of the definitions of your compensation, how important CO2 is in our body and how it regulates things. So if we retain CO2 based on poor ventilator management, or if the patient is just sick and unable to blow off the CO2 like in a COPD or asthma patient, then you're gonna have a patient that becomes acidotic because of the respiratory aspect. If you look at a VQ mismatch, if you remember my podcast on ventilator management and you think about the alveolar membrane where gas exchange occurs, and if you think about this big glass window, and that glass window in a normal patient would be perfectly clean. You can see right through it. Oxygen molecules would bounce off of it and penetrate it, and you'd have good diffusion where you have oxygen molecules jumping on, CO2 molecules jumping off, and you'd have good diffusion and gas exchange. You'd have good ventilation and perfusion. A VQ mismatch, though, imagine that same glass window, and imagine smearing mayonnaise all over the center of it. So now you have decreased surface area, you have a decreased area for gas exchange, and you have this big block. And so you have poor ability to utilize oxygen and to blow off CO2. And so that's essentially what a VQ mismatch is. And so you have that retention of CO2. There's a block there. It blocks the diffusion aspect. All right? So when we talk about how to correct for respiratory acidosis or how to prevent it, because we can definitely cause this in our management of our patients, we need to always think about minute ventilation. And I know this is a soapbox. If you've listened to my other podcasts on ventilator management, you'll understand that I'm real passionate about this aspect. We have to look at anatomical dead space. We have to look at dead space in our ET tube, in our vent circuit, and we need to calculate that when we calculate our minute ventilation. I go in depth on this in that ventilator podcast. I encourage you to go and look at it. I will put these notes on the forums page under podcasts, documents, and attachments, and I'll have this calculation. But essentially, we have dead space, and we need to calculate about 1 mil per every pound of body weight, or it's approximately 150 mils per breath that we lose in dead space, anatomical, vent circuit, ET tube, etc. So it's very easy for us in our management of our patients to cause hypoventilation, which again is going to cause respiratory acidosis. Or we need to think about what the patient's doing as far as their aspects of breathing. Do we need to intervene, RSI, put them on the ventilator, and take over breathing because they are unable to blow off the CO2? Do they have air trapping? Do they have compliance problems? Those are the types of things that will affect the patient negatively and cause that respiratory acidosis. All right, so if we talk about respiratory acidosis, then the pH and the PaCO2 will be affected. So you're going to have a pH that's going to be below 7.35, right? And you're going to have a PaCO2 greater than 45, all right? And so if you have those two things and everything else is normal, you have a respiratory acidosis. So it would look like a pH of 7.10 and a PaCO2 of 48. That's going to be a respiratory acidosis. The patient's holding on to CO2. That CO2 is affecting the pH negatively and driving it down. And basically, the way that calculation goes is for every 10 points we increase in our PaCO2, we decrease our pH by 0.08. So to give you an idea, a normal pH is 7.35. Range, I should say, the normal range for a pH is 7.35 to 7.45. So if we start with a pH of 7.35, let's say, and we have a PaCO2 that jumps up to 55, so we've got a 10-point increase, okay? That 7.35 pH would drop down to a 7.27 on our pH. Okay, so we've dropped 0.08 decrease in our pH. All right, so we would, if our CO2 jumps up to 55, our pH is going to drop down 0.08. All right, so for every 10 increase, we're going to drop our pH 0.08. For every 10 decrease in our CO2, we're going to increase our pH. It's always going to be in the opposite direction, and we're going to talk about that in podcast number 3, how we can really affect change. Remember, pH drives everything in our body. We're really going to be able to affect change, and if we use these methods, it's called the winner's formula. We can, with our flights that are 45 minutes to an hour, we can really change and correct these metabolic disorders and respiratory disorders. All right, so the next acid-based derangement would be respiratory alkalosis. All right, and remember, respiratory alkalosis is always going to be the first stage of shock, and it's very important to understand this, that in a shock state, we increase our respiratory rate and our breathing, we have that sympathetic response, and we start becoming a little bit tachypnic because we're trying to compensate, we're fighting, whatever, right? So that's going to cause an increased rate. If we cause an increased rate, we're blowing off our CO2 too quickly, right? We're losing acid, we're gaining bicarbonate, and that is in turn going to drive our pH up, right? So we have a pH of 7.4 is normal. Our pH range in the compensatory range is 7.35 to 7.45, and so in an acidosis state, it's going to be greater than 7.45. Other aspects of respiratory alkalosis, DKA patients, right? DKA patients will become very acidotic in the metabolic aspect because of the glucose and the potassium and all those things, and the dehydration, the loss of the extracellular ions like potassium, like I said. And so with that, the patient's trying to compensate. So the patient has a compensatory mechanism. They have those Kussmaul respirations. They breathe extremely fast. They're trying to blow off CO2. And by blowing off CO2, that's adding more base. You're losing more acid. And in a metabolic acidosis like you see in DKA, that's trying to flip that pH. It's trying to drive that pH upward. Remember, any increased 10 points in our PaCO2 is going to drive the pH either up or down based on which direction our PaCO2 is. So how do we do that in the field? Well, we can't check blood gases in the field, so that's where you're going to utilize your end-tidal CO2. And again, we'll talk about that in podcast number 3. Another aspect is aspirin overdoses. Aspirin overdoses are extremely difficult to manage. One aspect of those is that it attacks or changes the mechanisms in the hypothalamus in the brain, and it causes tachypnea and hyperventilation syndrome. Again, in the aspirin overdose patients, they're going to have a metabolic acidosis with that. So again, it's your body's way of compensating, and they're going to be breathing extremely fast, kind of like in a DKA patient. All right, so we'll continue on, and we're going to start talking about metabolic acidosis. And this is the big one. This is where we see a lot of these. And so with the metabolic acidosis, this is where you're going to start having, this is going to be longer term, right? So you're going to have a pH that's low, below 7.35, and you're going to have that bicarbonate level low, right? We have not enough base. Bicarbonate is a base. So you're going to have a low amount of base, and you're going to have that's going to cause the acidosis. So metabolic acidosis is basically an increase in the amount of absolute body acid, all right, either from excess production of acids or excess loss of bicarbonate. Remember, acids, CO2, bicarbonate base, it's a constant fluctuation. Hydrogen ions drive everything. So hydrogen ions are an acid, they're positively charged. Bicarbonate are negatively charged. They're constantly trying to equalize each other. Sodium is another big one. We're going to talk about sodium in podcast number 2. Sodium is a strong acid. Chloride is another one, a very strong acid. And then potassium is a huge one. Potassium is the most predominant extracellular element in our body. All of these things affect acid-base balance. We're going to talk about specifically sodium, chloride, potassium, albumin, those strong acids in podcast number 2, and I think you'll really enjoy hearing how you can look at your labs and understanding the different aspects of how to affect those things. All right, so how are we going to correct those things? What types of things are we going to see? Well, the first thing is always going to cause a metabolic acidosis, lactic acidosis. And if you remember from my podcast on cellular respiration, lactic acidosis is a direct result of lactic acidosis is a direct result of anaerobic metabolism. And if you remember glycolysis, the Krebs cycle, the electron transport chain is the whole process that our body goes through to convert glucose and oxygen to utilize as energy and convert to ATP, adenosine triphosphate. Adenosine triphosphate is the fuel for our cells. The aspect of anaerobic metabolism is that you don't have that oxygen-rich environment, and so you have the glucose molecule that's broke down and converted, and the process starts, but you don't have that oxygen molecule. That oxygen molecule is really essential to turn that ATP synthesis pump in the electron transport chain. And if you don't have that, then what happens is when you convert the glucose molecule to pyruvate, the pyruvate molecule has nothing to utilize to convert and break down to cause a formation of ATP, and in turn the byproduct is lactic acid. Okay. If you want a more in-depth understanding or an explanation, you can go to the Cellular Respiration Podcast, and I break it down pretty in-depth. So the primary suspect for metabolic acidosis is lactic acidosis. And essentially, lactic acidosis or a lactate level is a tissue marker for oxygenation. It's also a very important biomarker for mortality and morbidity. It's more looked at towards the mortality and morbidity now than a tissue oxygenation marker. But anything greater than 2.5 on your lactate level, every point above that is a 10% mortality rate increase for your patient. So you can imagine if you had a 5 lactate level of 5, you're going to have a 25% increase in mortality just based on that alone. So it's very important. The thing with a lactate level is that a lot of the smaller facilities don't draw lactate levels. It's seen more only in the bigger facilities, the bigger ICUs and things like that. So a lot of the smaller facilities, you're not going to have that when you go transfer these patients. The second cause of metabolic acidosis is going to be DKA, and we talked about DKA a little bit in the initial part of this podcast. But DKA, obviously, you're going to have an increased glucose level. You have severe dehydration. You have a ton of ketones. And this causes Obviously, kidney involvement. The kidneys excrete the bicarb out, and that causes less base and more acid. And then you also have the element of you have all this volume depletion because the patient's peeing so much, and so you lose all that potassium. Remember, potassium is a strong acid. Potassium is really important in the whole process of the hydrogen potassium pump and how all that works. So you have a lot of aspects there. So we need to correct that. We need to get the glucose down, and we need to look at the potassium very closely. A lot of times with DKA patients, they're going to actually be hypokalemic, even though their potassium on their lab shows high. Remember, in any metabolic acidosis, you're going to probably see on your labs a high potassium, and that's a false number. That's not correct. Doesn't mean you have too much potassium. It just means that there's potassium that's shifted out of the cell into the bloodstream. That needs to be corrected. That needs to be fixed because the heart doesn't like that, but it doesn't mean you have too much potassium. So we need to always correct the metabolic acidosis before we touch the potassium. The one instance where you want to worry about the potassium, and like I said, the initial phase of DKA is most patients are hypokalemic, and they're hypokalemic because they've excreted all this urine out and it's pulled all this potassium out of their body. So they need to be given potassium regardless of what their lab results show. Even if their lab shows a high potassium, you need to be giving them potassium. You need to correct the metabolic acidosis because I can tell you correcting a hypokalemic state you cannot do quickly. It's very ominous, very, very bad for the patient, so we need to account for that. The third thing is going to be renal failure. Obviously, if you have acute or chronic renal failure, this can cause a metabolic acidosis. And all of this is kind of intertwined. If you think about, acute renal failure in trauma patients, well, why are they in acute renal failure? Are they in acute renal failure because they have profound tissue hypoxia? Were they not oxygenated well? Did they lose blood volume and they have that hypemic hypoxia, right? They don't have the oxygen carrying capacity. Do they have rhabdomyolysis and they have massive kidney failure because they've got this influx of myoglobin, which is very toxic? So those are all these aspects that can cause a renal failure or long-term renal failure in these diabetic patients, obviously. So we're going to look at our BUN and creatinine. We're going to look at our tissue functions. We're going to look at our urine output. Our urine output on these patients needs to be a minimum of 30 to 50 mils per hour. And I know for me, looking at this prior to getting into flight medicine and critical care medicine, I didn't really worry about urine output. But remember, urine output is going to tell you how sick your patient really is. If they're producing urine, then you're actually pretty stable. Your kidneys are working, and that's a good thing. That's a good sign. Remember, cardiac output is essential. So if you don't have good oxygenation, you don't have good cardiac output, and that's going to drive oxygenation to your kidneys and to your brain. 25% of your oxygenation goes to your brain, and another 25 to 30% goes to your kidneys. So all of this kind of plays into each other. So let's quickly talk about the different types of shock. And I'm not going to go into hypovolemic shock and obstructive shock and anaphylactic shock, not those types of shocks. I want to talk about kind of the subcategories of those. So we got hypemic hypoxia, histotoxic hypoxia, hypoxic hypoxia, and stagnant. All right, so hypemic hypoxia is going to be a blood volume problem. We don't have good oxygen carrying capacity. We have a low H&H. We've got a low hemoglobin and hematocrit level, and we don't have the ability to carry oxygen on our hemoglobin. So obviously, if we don't have the ability to carry oxygen on our hemoglobin, we can't oxygenate our tissues. So this obviously will cause a metabolic acidosis because that will cause a lactic acidosis. It's pretty neat. I think this stuff is pretty neat because everything is intertwined, and really you can trace everything back to good old-fashioned oxygenation. If you always go back to how can I optimize their oxygenation status, what can I do to fix that? A lot of times you'll correct a lot of issues. The next one is histotoxic. Histotoxic is going to be obviously overdose, a DIG overdose, tricyclic antidepressant overdose, digoxin overdose. Any poisons will obviously cause a histotoxic shock state, and that's going to cause that metabolic acidosis. Aspirin overdose is another one. All right, hypoxic hypoxia. that's going to be that lactic acidosis. So what can we do to fix the hypoxia? What can we do to optimize cardiac output? And then the last one is stagnant, right? Stagnant is going to be cardiogenic shock. It could be obstructive, like a tension pneumothorax, a pericardiocentesis, it could be obstructive in the nature of tension pneumothorax. It could be a pericardial tamponade. It could be a PE, cardiogenic shock. So all of those things cause a stagnant state of shock, and you're going to have reduced cardiac output, which is going to in turn affect oxygenation to your tissues. Again, it's going to relate to lactic acidosis, and it's going to affect oxygenation to your kidneys, which is, again, going to go right back to your acute renal failure over time, and it's going to affect oxygenation to your brain. We all know what that will do. So again, proper hydration, 30 to 50 mils an hour of urine output. If you have a burn patient or a patient that's in a trauma situation that has potential for rhabdomyolysis, you want to increase that to about 100 mils an hour. The DKA, we need to fix the DKA. We need to give them tons of fluid. We need to start them on insulin. We need to drop that sugar. We need to worry about, giving them potassium if they're already potassium depleted. Most likely, again, they will be. On the toxin aspect, we need to correct for the toxins. Are there antidotes can we give? Can we stop a medication that we're giving that's causing this, etc.? And then the last one is going to be metabolic alkalosis. And the big thing with this is either you have either too much bicarb, right? Bicarb's a base. It's a negatively charged ion. Or you have too little hydrogen, right? Hydrogen is an acid. So if you don't have enough acids, you have a base there. So always think electrolyte disorders in this situation. Whether it's nausea and vomiting, diarrhea. With a diarrhea, you're going to have severe potassium loss. Is it GI loss of acid? And how would that happen? Well, if we have an ICU patient and they're constantly being suctioned via an OG or NG tube, we're suctioning all this acid out. And remember, again, acid, as in hydrogen ions, needs an opposite. Opposites attract, and that opposite is bicarbonate. So if we suction all this hydrogen out, what are we going to have left? We're going to have excess bicarbonate left, and you're also going to have probably a depletion in potassium. So kind of the way that works is if we lose hydrogen ions due to the hydrogen potassium pump, you're doing this because it's trying to salvage as much potassium as possible. Okay, this decreases the hydrogen, and it doesn't allow the buffering of the bicarb. Right, we have to have the bicarb to buffer the hydrogen. And so we're suctioning out all this hydrogen. It's affecting the potassium, and it's also affecting the buffering system of the bicarb. And this is causing an excess amount of base, the bicarb, and that in turn causes the alkalosis. This is a bad thing. The metabolic alkalosis thing is the worst of the worst. It's very ominous for our patients. And you can see just by a few things that I've talked about, we can cause this with our care and our treatment in the ICU. Obviously, the nausea, vomiting, diarrhea is going to be secondary or a secondary cause. So that's all I have for this podcast. There's a lot of information I talked about. Let's go back really quickly to the scenario. We have the pH of 7.10. That's going to be an uncompensated. We have PaCO2 of 60. That's going to be too many acids, right? Too many CO2. So that's going to be an acid. And we have bicarb of 16. That's going to be an acid. So in this patient, we have a mixed disturbance. We have an acidotic pH, we have an acidotic CO2, and we have an acidotic bicarb. So this guy's probably based on his vent settings, he's the respiratory aspect is increased because he's either air trapping, his ventilator settings aren't appropriate, his sedation is appropriate, but his underlying problem because of the sepsis and the ARDS is probably a lactic acidosis that's causing a metabolic acidosis. And then his PaO2 is 40, and we know a normal PaO2 is 80 to 100, so he has a hypoxemia added on there. So again, I want to thank you for listening. This is part 1 of the acid-base balance. I look forward to having you join me for part 2, where we're going to go into the strong acids, the sodium, the chloride, the albumin, and the potassium, how that affects acid-base balance, and so we can understand that a little bit more, so we can look at lab values when we're in transport with our patients, and be able to identify truly what's going on with our patients. So thank you so much for joining me, and I'll talk to you soon.